morning everyone. I am Dr. Tarang Shah. I am Assistant Professor in Cardiology Department of UNMICRC Institute of Cardiology and Research Center. Today we are going to discuss about cardiac sarcoidosis. Sarcoidosis is a heterogeneous disorder of unknown etiology whose signature lesions are non-causating granuloma. It is a set of pathologies that occur owing to both active inflammation and granulomatous scarring in the heart and other extracardiac tissues. The clinical presentation of cardiac sarcoidosis ranges from incidentally discovered condition to heart failure, brady and tachyarrhythmias, and sudden cardiac death. Most often it occurs as a manifestation of systemic sarcoidosis, although isolated cardiac sarcoidosis can occur, but it is a rare scenario in which patients do not have evidence of sarcoidosis in other organs. While endomyocardial biopsy provides a high specificity for diagnosing CS, this invasive test has a very limited sensitivity. So if we look into the prevalence, it estimated 5% of patients of sarcoidosis have cardiac involvement, but 25% of patients of cardiac sarcoidosis have isolated cardiac sarcoidosis. With increasing use of cardiac MR and FDG PET scan for the diagnosis of sarcoidosis, the prevalence of isolated cardiac sarcoidosis is decreasing. So recent study showing it to be approximately 2 to 10%. Autopsy and imaging studies which have been performed in US and other countries, it is found to be as high as 20 to 30%, and in some series of Japan registries it is 70%. Approximately 20% of death is due to cardiac cause, and most common cause of death is sudden cardiac death due to bradyarrhythmia, tachyarrhythmias. Average age of presentation is approximately 50 years. So if we look into the pathophysiology, there is formation of non-causating granulomas. Pathologic features include 3 successive histological stages. First is edema formation, second is granulomatous inflammation, and third is fibrosis leading to post-inflammatory scarring. The ventricular myocardium is the most commonly involved structure, and most commonly affected site is LV free wall and papillary muscle, followed by basal interventricular septum, RV free wall, and least commonly involved structures are atria, valves, coronary arteries, and pericardium. So clinical manifestations, respiratory complaints including cough and dyspnea are the most common presenting symptoms because the most commonly involved organ is lung. Symptoms related to cutaneous and ocular disease are the next 2 most common complaints. Non-specific constitutional symptoms include fatigue, which is the most common symptoms. Fever, night sweats, and weight loss can occur. The overall incidence of sarcoidosis at the time of diagnosis and eventual common organ involvement are summarized as below in the table. So as I said, the lung is the most commonly involved organ, which is involved in 95% of patients. And if we see down below the table, cardiac sarcoidosis is only found in 2 to 5% of patients. The presentation of cardiac sarcoidosis can be any of the following, like AV blocks, arrhythmias, cardiomyopathy and heart failure, sudden cardiac death due to bradyarrhythmia, tachyarrhythmias, and coronary artery disease, which is very rare. Other least commonly involved structures are, like I said, pericardial effusion, constrictive pericarditis, and tamponade occurs rarely. So first, atrioventricular block. Most common clinical presentation is AV blocks. Complete heart block can occur. First degree AV blocks due to disease of the AV node or bundle of His, and intraventricular conduction defects can occur. Second degree AV blocks are also commonly seen. If we look into the arrhythmias, ventricular arrhythmias, which is the second most common cause of presentation in cardiac sarcoidosis, patient may present with VT, NSVTs, isolated VPCs. SVTs are rare manifesting symptoms but can occur anytime throughout the course of disease, which includes the paroxysmal atrial tachycardias, flutter, fibrillation, sinus arrest, or sometimes pauses. Sarcoid granulomas within the myocardium become the foci of abnormal automaticity. Second is heart failure. Any form of heart failure like dilated, restrictive, or arrhythmogenic cardiomyopathy can develop in patient with cardiac sarcoidosis. It is the third most common presentation. Patient may sometimes present with symptoms of predominantly RV pump failure, in which it is important to differentiate it from ARVC. Coronary artery disease, as I said, it is least common. Vasculitis may occur, spontaneous coronary artery dissections are seen. Typical coronary artery disease in sarcoidosis, it is rarely seen. So which are the predictors of sudden cardiac arrest in sarcoidosis? Age at the presentation, which if less than 40 years, African American individual, presentations of atrial fibrillation, FPEP symptoms, LBBB, heart failure with reduced ejection fraction, and other types of heart blocks. So how to investigate the patient with cardiac sarcoidosis? Blood investigation are less commonly helpful because its sensitivity and specificity is low. Serum calcium and ACE levels can be observed. Its sensitivity is 62% and specificity is 76%. Other inflammatory markers like ESR, CRP-Q can be helpful, but it is less commonly helpful in chronic stage of the disease. Radiology may be helpful, chest x-rays are helpful, mediastinal lymph nodes, bilateral lymphadenopathy can be found. CT thorax helps in the diagnosis. Commonly, lung is the most commonly involved organ, so it typically picks up the disease in the lung parenchyma. Cardiac MRI and FDG PET are the most commonly useful investigation for the cardiac sarcoidosis. So other invasive investigation like endobronchial ultrasound guided lymph node biopsy or needle aspiration from the lung lymph nodes and bowel fluid lymphocytosis and CD4-CD8 ratio of more than 3.5 in asymptomatic patient and more than 4 in symptomatic patient is diagnostic. The presence of any one or more of the following clinical features are helpful in suspected patients of sarcoidosis. These manifestations include uveitis, renal stones due to hypercalcemias, 7th cranial nerve paralysis, and erythema nodosum. So the diagnosis in 2014 Heart Rhythm Society it gave the expert consensus statement. Detailed history and physical examination are utmost importance, followed by cardiac MR and FDG PET. If the patient lacks the histological confirmation of sarcoidosis, the feasibility of extracardiac or endomyocardial biopsy should be assessed. So Heart Rhythm Society proposed that clinical diagnosis should include all three of the following: histologically confirmed extracardiac sarcoidosis plus exclusion of other causes of cardiac dysfunction and at least one imaging ECG or functional finding consistent with cardiac sarcoidosis. What are the ECG findings that are helpful in the diagnosis of cardiac sarcoidosis? PR interval prolongation, second or third degree AV blocks, QRS prolongations, frequent PVCs, atrial arrhythmias, pathological Q waves, and non-specific ST segment and T wave or abnormalities can also be found. So ECG evidence of AV nodal dysfunction or distal conduction disease should raise the suspicion for cardiac involvement in the young patient, like if patient 40 to 60 years of age of patient present with this ECG finding, and there is if you are not suspecting degenerative heart blocks, you should suspect sarcoid. There are associated with increased risk of sudden cardiac arrest. However, the presence of normal ECG does not reflect that there is a low risk of sudden cardiac arrest. So what are the criteria for advanced cardiac imaging? If patients who have biopsy proven or clinically diagnosed extracardiac sarcoidosis and one of the following symptoms or signs are consistent for cardiac sarcoidosis, it suggests that we should go for advanced cardiac imaging like MR and FDG PET. What are the symptoms or clinical signs? Symptoms are prominent palpitation which last more than 1 to 2 weeks, pre-syncope or syncope. One or more of the following ECG abnormalities like complete left or right bundle branch block, presence of unexplained pathological Q waves in 2 or more leads, sustained first, second or third degree AV blocks or sustained non-sustained VTs. If echocardiographic abnormalities are found like regional wall motion abnormalities, ventricular aneurysms, basal septal thinning or depressed LVEF. Without extracardiac sarcoidosis, how to go for advanced cardiac imaging? In patients with no prior history of extracardiac sarcoidosis who have one or more of the following conditions, they are indicated for advanced cardiac imaging like unexplained second degree Mubitz type 2 or third degree AV block in patients age less than 60 years. Sustained monomorphic VT in the absence of any known etiology. Advanced cardiac imaging. In previous era, thallium scintigraphy and gallium scintigraphy were used, but nowadays FDG PET and cardiac MRI are the most commonly used investigation. So FDG PET demonstrated higher sensitivity for the detection of myocardial involvement than the thallium and gallium scan. The specificity of FDG PET for diagnosis of cardiac sarcoidosis is yet to be confirmed, as heterogeneous myocardial FDG uptake was also observed in patients with idiopathic dilated cardiomyopathy, and it found to be correlated with poor prognosis. So the next investigation is cardiac MR, most commonly useful investigation. Zones of thinning and segmental myocardial wall motion abnormalities with increased intramyocardial signal intensity on T2 weighted images are associated with inflammation and granulomatous lesion. It suggests the active disease. Early detection of cardiac sarcoidosis and evaluation of response to steroid treatment can also be done. So sensitivity and specificity are very high, which is 100% and 78% respectively. So it can also be used as an accurate guide to obtain endomyocardial biopsy specimen. Preferred initial test has also been made by American Thoracic Society. EPS is less commonly helpful. Some observational studies suggest that EPS testing may help identify the patient with cardiac sarcoidosis who are at risk for development of ventricular arrhythmias and who are in need of ICD. So which are the predictor of mortality? Most important is the left ventricular ejection fraction at the time of presentation. Others are NYHA class, left ventricular end diastolic diameter, if patient is having sustained VTs. So Japanese Ministry of Health and Welfare gave the diagnostic criteria for diagnosing cardiac sarcoidosis. It is divided into two groups. First is histological, which is done by endomyocardial biopsy, and second is clinical diagnosis group, in which patients who have histological diagnosis of extracardiac sarcoidosis and cardiac sarcoidosis is suspected when patients have complete RVBB, left axis deviation, AV blocks, VTs, abnormal wall motion abnormalities, regional wall thinning and dilatation of ventricles, perfusion defect as detected by thallium scan, abnormal invasive monitorings like intracardiac pressure, low cardiac output, and interstitial fibrosis or cellular infiltration over moderate grade. The next is criteria given by Japanese society, in which the patients are found to be highly probable of, in which laboratory manifestation which are highly probable for the diagnosis of cardiac sarcoidosis are bilateral hilar rim adenopathy, second is elevated serum ACE levels, third elevated soluble interleukin 2 receptor levels, significant positive uptake on FDG PET, and as previously said, increased CD4 by CD8 ratio on bile fluids. Sarcoidosis is considered highly probable if more than two criteria have been met. Other clinical manifestations which are highly probable are divided into major and minor criteria. Major criteria includes high-grade AV blocks, basal septal thinning, LV dysfunction, significant FDG PET update, and late LG enhancement on CMR. And minor criteria includes ventricular arrhythmias, focal defect which is detected on CTs, and monocyte infiltration on CM. What are the differential diagnoses? Tuberculosis, viral myocarditis, Lyme's myocarditis, maybe any other forms of myocarditis can mimic cardiac sarcoidosis, and other types of conduction system disease, other cardiomyopathies, and ischemic heart disease. So what is the treatment option? Treatment of cardiac sarcoidosis comprises of three parts: anti-inflammatory therapy, anti-arrhythmic therapy, and ICD implantation. There are no randomized control trials for the treatment of cardiac sarcoidosis, particularly individually. So corticosteroid treatment, there is still controversy about the clinical efficacy and optimal initial dose and duration of steroid treatment for cardiac sarcoidosis. It may halt the progression of cardiac disease and improve the survival. However, it does not seem to reduce the incidence of ventricular arrhythmias. What is the mechanism of action of steroid? It is unknown, but it is believed that these agents are capable of slowing the progression of inflammation and fibrosis through re-establishing the T helper cell response. Initial starting dose is 60 to 80 mg of prednisolone, which is generally prescribed, and in another study, starting dose was said to be 30 to 40 mg. Prerequisite for steroid tapering or withdrawal include the absence of disease activity, which is confirmed by CMR or FDG uptakes. The role of steroids and other immunosuppressants in the treatment of CS, however, is less well established. Their primary use is resolving active granulomatous damage and preventing the progression of the disease and preventing the mortality. This is especially useful in AV conduction block with mixed evidence of ventricular arrhythmias. So reports have emphasized the role of corticosteroids for the conduction abnormalities even in the case of late initiation. In heart failure, the role of corticosteroids is insufficient. So as I said, we should initiate prednisolone 60 to 80 milligram per day, and then we have to reevaluate the patient in 2 to 3 months. If patient is responding, CMR is improving, we have to gradually decrease the dose over 6 months, and maintenance dose is 10 to 15 milligram per day, and then we have to taper and may discontinue if no evidence of disease is found on CMR. If the patients are non-responders, alternative therapy, which are steroid-sparing therapies, are antimalarials, methotrexate, and azathioprines. So as I said, steroid-sparing agents are antimalarial, methotrexate, azathioprine, and cyclophosphamide. If patients do not respond with this therapy also, third line of management is anti-TNF therapy, which includes etanercept, golimumab, infliximab. Side effects includes infection, pancytopenia, hepatitis. So use of these agents should be reserved for only the non-responders to steroid and additional anti-inflammatory therapy. In refractory cases, rituximab has also been tried, but no significant clinical evidence. The next is antiarrhythmic treatments. It includes the antiarrhythmic drugs and beta blockers. So there have been no prospective studies evaluating the use of these agents in cardiac sarcoidosis, as these agents are helpful in ventricular arrhythmias associated with other heart failure and cardiomyopathies. So they are used in this condition also. So though there is no proven role as prophylaxis of beta blockers, but it might actually increase the risk of heart blocks, and amiodarone could exacerbate restrictive lung disease and sarcoidosis. So what is the role of pacemaker and defibrillators? Pacemaker implantation may often become necessary if the conduction system is extensively involved. ICD placement for patient with cardiac sarcoidosis has not been thoroughly evaluated. The mechanism of VT in sarcoidosis is re-entry and different inducibility between active and inactive phases. In patients with refractory ventricular tachyarrhythmias who are at risk of sudden cardiac death, treatment with ICD is mandatory. Some experts would also recommend ICD placement in any patient with sarcoidosis and non-sustained VT, given that there is high rate of recurrence of VT despite all the medical management. VT can occur during the first 6 months of successful suppression of disease activity with steroids. So the guideline says we have to give the ICD therapy along with the disease modulating therapy. What is the role of cardiac transplantation? Cardiac transplantation for sarcoidosis is a rare as a recurrent disease in the transplanted, as the recurrent disease in transplanted heart can also occur because it is autoimmune disease. So cervical sympathectomy has also been shown to reduce the ventricular arrhythmia burden, and implantable cardioverter defibrillator shocks in patients with resistant VT. So if we summarize the treatment, patients having extracardiac sarcoidosis with any abnormal symptoms of or cardiac manifestations, ECG signs, ejection fraction of less than 50, we should consider CMR in that patient. If the CMR is normal, annual follow-up can be done in these patients, and clinical examination regularly can be done with symptoms and signs. And if MRI is found to be abnormal, then we have to consider for FDG PET to look the disease activity. If the FDG PET is absolutely normal, then ICD can be considered on the basis of patient's arrhythmia and other symptoms. But if FDG is found to be abnormal, ICD should be considered urgently, and additionally anti-inflammatory therapy should be added and steroid should be started. So this is all about cardiac sarcoidosis. Thank you.